Welcome, everyone. It's really amazing to have you here today for this really important session. Thanks to all who have volunteered the time, members of the Mental Health Action Group, and our families, our communities who make our work possible, and all of you who are so committed to mental health and to bring compassionate support for all. Today, we have a lovely combination of hearing from incredible campaigns, grassroots forces, caring for our communities, data behind the use of our mental health system, and a very solid section at the end of our conference today, where you will be sharing your ideas, suggestions, and lived experience on how you think we could improve mental health community support for all, and especially, of course, always compassionate. Now, we have been very, very active communicating with ICBs across the country, sharing knowledge, data, and concerns. And today won't be any different. We will be posting this session online, so we'll make it another resource to be sharing and bringing this issue across NHS, ICBs, and trust in the country. And also, we will be sharing the collective thoughts that we're gathering today. Now, we will be also sharing some links, which we'll be posting in the chat. That chat is going to be our main channel of communication today, whilst we're having the sessions. And at the end, of course, people will have the right, to share the space and speak and share your thoughts. Now, we have a team of volunteers helping us. Terry is very kindly supporting us with monitoring the chat. So, your thoughts, ideas, we will be picking up on them and then be sharing throughout the sessions. Feel free to say where you are connecting from, your name, and perhaps an organization that you might want to get sort of connect and start building a network as well. Also be aware that, of course, everyone else will be seeing it, so share as much as you wish, feel comfortable with. And then thank you so much to the members of the Mental Health Action Group who have made this work possible. To volunteers such as Frank, my lovely partner who's helping us with the Zoom, and of course, Terry monitoring the chat. And that's it. That's me. I'll be chairing throughout the session. I am so excited to be here. So excited. I'm so excited to be part of Mental Health Action Group. As you can see, I love talking. So it's been a great combo that we've had.
Great chair.
I found my home, finally. I'm so happy. This is the right group to be with. I've been a campaigner for mental health for a long time. I'm myself a person-centered counselor, and also I'm a counselor for Hackney. So it's a strange combination, but it works so far. So, right, we're going to hear now from our first speakers. Happy to have... Sorry?
Recording?
Are we recording or
We're
no?
going to say something about recording.
Thank you, Paul.
Yeah.
You see, we work really well as a team.
Yeah.
It's really teamwork. Thank you, Paul. So we are recording this session because we're going to put it on YouTube very early next week. So then it, as I was saying earlier, becomes a bit of a resource as well. Okay? I hope that's okay with you. Lovely. Right. On to our first amazing team of speakers. So Leah Cranswick and Fen Harris. Leah and Fen are coming to talk to us about community mental health in Norfolk and Suffolk. They are campaigners and service users from Norfolk who have set up an art collective using creativity to explore, express, and communicate difficulties experienced in mental health system. Not safe for treatment have brought formerly isolated people together in various exhibitions and workshops to unite through artwork and use creative ways to explore how to make things better. They promote making positive, purposeful community creations from unresolved and difficult experiences. And within a safe space, artists can be proud and supported when showing their work, often for the first time. Welcome. So nice to have you here, both of you.
Thank you. Thank you so much, Claudia. I think Paul has got some of our slides to show everybody. That's great, Paul. Thank you so much. Hi everybody. Good morning. We wanted to bring a service user perspective to the conference today, and I think we're just really grateful to have been asked and actually to be involved with Mental Health Action. because the service user voice sometimes isn't used effectively. It's often brought in as a tokenistic thing or to tick boxes. And often service users can be busy focusing on staying well or be scared to speak up. And scarily, a lot of vulnerable people can actually not realise that they're witness to bad practice within their care. Please bear with us, occupational hazard that we've both got a bit of a nervous disposition, but we hope you enjoy our presentation. Next slide. Thanks, Paul.
Ida.
So yeah, this is us. You've just heard from Fen. I'm Leah. We connected because we're very similar, both navigating services at the time, and wear various hats now. I think as we moved through the system, we didn't turn up thinking we were going to become campaigners and end up doing projects for change. We just thought we were going to navigate this system and get better. However, it didn't exactly work like that. And I think where we're from, our services haven't been great, very inadequate in terms of like the regulators and stuff. So we were seeing firsthand what it feels like to be thrown into a system and specifically into a service that is not up to standard. And actually, the priority when you are somebody and when you're people who are have always been focused on social justice, I think there was sort of like a compulsion of feeling of like we need to do something about it, but not necessarily knowing how to do that. And so the combination of I think that experience makes it impossible to walk away. Like there was the two focus. So it was hard to get things sorted through the usual channels. And so we came together, took our passions, took our illness as well, and tried to turn it into something that could make positive change. And yeah, we formed Not Safe for Treatment.
So the background is that we actually met in a waiting room in the youth service, and I think I just sort of gave Leah a thumbs up because she looked terrified in the corner. And after each one, we saw each other again outside of the building and had a chat. And after meeting up a couple of times over a cup of tea, we realised we both enjoyed art. And we talked about our experiences that we felt very isolated with, I think, and that we felt that they were very independent to us, and we were made to feel as well that we were the only ones going through this thing. And we realised how similar our stories were. We also joined the local campaign, which is the campaign to save mental health services in Norfolk and Suffolk. And we began to just sort of dip our feet in there and realised actually that it was a huge problem locally and nationally. And that I think what we thought were things fundamentally wrong with ourselves was actually quite a systemic problem. So as time went on and we became good friends, we made art together and realized actually the benefit of starting to use creativity to maybe tell some of these stories and actually work through some of those frustrations that have still actually never been resolved. Next slide. Thanks, Paul.
So yeah, we just thought we'd give a little bit of a background on Norfolk and Suffolk. It's now not really an outlier because the national services have followed suit, but at one point this was the trust that was the worst in the country. It was the first mental health foundation trust to be put in special measures, and the campaign was set up 13 years ago at a public meeting in Norwich by service users, carers, bereaved families, but also frontline staff who were involved with NSFT, which is the Norfolk and Suffolk Foundation Trust. These staff were concerned about the impact of the radical redesign, which was it was forced by 20% funding cuts imposed by the coalition government. And this radical redesign was basically imposing cuts on vital services, so stripping back what was existing and what was actually helping people. And it resulted in a lot of experienced staff being downgraded in pay, but given more workloads. They were made to fight for their jobs, and experienced staff were forced to leave altogether. Campaign members, and particularly a founding member of the campaign, Terry O'Shea, was monitoring mortality data and was consistently raising concerns about the number of deaths at NSFT. alongside the suspicion that the trust was actually losing count of how many people had died, which you don't want anybody to die, but if they do, it's important that you do keep track of that, because otherwise, how do you know the picture? How do you know what's going on? So he was persistent in campaigning for that to be monitored, but also it was a way of saying, like, look, we knew this was going to happen. That's why we set up this group, and exactly what we said is happening. And yeah, people were unable to access the care that they needed. Staff were getting burnt out. Carers were fighting for, I mean, it's still like this, but yeah, carers were fighting for their loved ones to get appropriate care and treatment, and actually, like, nothing was changing. People weren't listening. So that's a little bit of the background. Next slide, please, Paul.
Yeah, so just a little bit more. Those deaths did continue to rise, and the trust, whether it's service users, carers, the public, and the staff, have seen this kind of carousel of replacing leadership that said they'll fix it and they'll fix it, and we've just been told this repetition over time. So yeah, we've had 10 CEOs in 10 years, and we've recently had another load of leadership, and I think a lot of people are really struggling to trust that the improvements will stick, and that the intention is there actually to look after the population. We've had probably the most CQC inspections in the country, and we've gone to government many times, raised issues, and actually there's been neglect across the board from regulators and the government. Next slide, please, Paul.
So yeah, this is our final slide on sort of the background. But staff have talked for years openly about working in a culture of fear where, and I think this is important, also speaking up and whistleblowing feels risky. And instead of being able to just, get on with your job, they're bracing for the next crisis all of the time and not feeling supported by the trust that they're working for to do their job well. On top of that, like Fenna's just said, we have seen repeated failed transformation plans and countless set of new management. It's always this top down, bring people in from other places around the country who don't really understand Norfolk and Suffolk and the rurality of it. But they come in with hope and promise, and we get told the same thing every time. And I think over the years, the hope has just sort of faded out. Everybody you speak to as well, everybody you come across and you meet has a story to tell about this trust, whether that be that they've lost somebody, that they've had to fight for care and they've still not got it, that they've been left in crisis. And I think the thing I really struggle to communicate to people who aren't from the area and haven't interacted with the trust is this collective grief and trauma and massive distrust of the service. I mean, if you think about mental health care, like, you're going there in your most vulnerable, and yeah, that distrust, no matter how many times you get told that things are changing, it has persisted, and it continues to persist. And additionally, if there is they sorry, I've messed my words up, never mind, I'll come on to that later. Next slide, Paul. Occupational hazard is true.
Don't worry.
So I thought I'd just mention our sort of personal experiences. So I went into services in early adulthood for depression, OCD, and emetophobia. And I think quite early on, the trust sort of put a narrative on me that I didn't really understand. I was put through treatments that actually made my conditions worse. They missed what was happening in my home environment, and they convinced me that the issues that I had weren't actually the problem. I think because they didn't believe what the fear could actually do and how it was affecting me. I think they were trying to find other reasons for it because they didn't quite understand. But throughout my time in services, I haven't been listened to. There was so much confusion, a lack of clarity. I was put into a discharge meeting when I needed the most help, when actually I was accepted by specialist care in London. So they were happy to just discharge me back to my GP when I was that unwell. And it was through luck and the love of friends and family and knowledge of them finding this specialist help for me, which I was accepted into, that saved me actually. And I think all of us can hope to believe that it shouldn't be luck to get people the treatment and that they need and actually survive that treatment as well. I was told that there's no chance for me. I was called skinny and dishevelled. I was told to expect the worst, and my family were told to expect the worst. And I think all the way through, there was very much this rather than a carrot and stick, it was very much keys to the door, and very much an experience of moving goalposts. So I'd be told that I might get a certain treatment if I did something, and then that would change. Or I'd be told I may get a support worker, and then I was told that I was going to be discharged. And there was a lot of this all the time. And just a feeling, I think, of a lot of it was just through tick boxes and really putting the burden on services about the lack of resources. That was really heavily put on our shoulders, I think, of uh, you already feel quite worthless in those situations with the power struggles. And so to be told by the professionals of the resources you're taking up, or you're taking up too much time, or their caseloads are too big, to be told that as a service user, it really, really makes it difficult to try and seek that help for yourself, I think. Thanks, Paul. Next slide, please.
So yeah, my experience was heavily in a young people's service that was 14 to 25 years. I was in touch with mental health services right from being a small child, 12 years old, due to anxiety and traumatic experiences. So I'm presenting already as somebody who is very anxious and I'm thrown into the system. I always remember as well, like, this was the first time I'd seen the NHS as being like not so good, and that always sticks out to me because it was always like the NHS is always going to be there for you, like you're safe with them. And yeah, this was the first time where I was a bit like eyebrows raised and like I don't entirely feel safe here. But in that service, from about 16, I was experiencing over medication, a denial of treatment, inappropriate therapy modality leading to re-traumatization, and eventual giving up on discharge by letter after being in the service for a really long time. From that experience, it's taught me, and like this, just going to put it bluntly, that all I am is a risk to be managed, a set of labels attached to me from a place of subjectivity, an outcome to be measured when it suits, a case to be processed, a set of behaviours to control, pages and pages of records, a failed intervention, and too complex, don't fit the boxes. That's what it ended at. And I think the topic of young people's mental health is something that comes up all of the time in the news, and it's coming up more now. It's something that needs to be focused on, but it's really worrying to me that my experience in that service started 10 years ago, and since then we've had chronic underfunding, and we're going to continue to have chronic underfunding, and so this will get worse. And I think one of the things I carry with me from that experience is this question of what if I had been able to access safe care? What if I had been able to access appropriate treatment? I did present young. I lost my formative years to that service. I lost my education. I lost my friends. I didn't have a normal teenage experience. And I think that's something that needs to be a priority now and also needs to be spoken openly about, because there will be other young people well, there'll be adults in the future who, as young people, are presenting to these services now, who will be asking the same questions if something doesn't change. Ultimately, I entered these services being told to trust the helpers and actually left more harm from the care. There was a lack of opportunity to build relationships with those helpers, and it's just resulted in a massive distrust of the system. After a decade of less than ideal support, I found out that the attitudes and approaches that I had been on the receiving end of had been slowly normalised within UK mental health services for a number of reasons, which we'll talk about later. And there are lots of things to hold in mind with that conversation. But yeah, the picture I put on the slide is a piece of artwork I made that says "still recovering from reaching out," because that is where I am now. It's recovering from those experiences as well as all of the things I originally presented with. But this is not a sob story, I promise. Next slide, please, Paul.
Oh, sorry. We'll be able to go back one. Thank you very much. Just through the theme of this conference about the erosion of compassion, even as service users navigating the services, We've noticed that there's a lot of bureaucracy, there's exclusionary criteria, things are very confusing, there's ever-changing rules, time constraints, resource management, dehumanization of patients and staff, tick box exercises over curiosity, and reputation over genuine resolution and rectification. Next slide, please, Paul.
Yeah, so this is just a continuation, and this is something that me and Fen talk about a lot. I went into health and social care, and I loved the NHS, and I was very naive in looking at the NHS as like this care model. And by definition, the NHS is not a business. However, because of the years of underfunding and the constant pressures, it now has to behave like one in lots of ways, and that's detrimental to both the people working in it, but also the people trying to seek care from it. Services are now driven by targets and performance measures. Staff are pushed and forced to think in terms of outputs and efficiency and strict resource management rather than human need, which I think we can all agree that's why most people go to work in health and social care professions, because they care about people. In practice, that means that it forces everybody into sort of having to make these decisions that are influenced by the scarcity of the resources. So they're asking the questions of who is urgent and needs to be seen, who is treatable within the time limits of the service, who is worth the time, which you never want to think about, but it seems to be going that way, which then leaves both the patients and the staff in difficult situations. So it actively kills the compassion that brought many people to working in the NHS, to the NHS workforce, but it also increases the feelings of hopelessness that keeps distress going for the people who enter them. Next slide, please, Paul.
Yeah, so we feel like the impact where already, you're coming in a really vulnerable state, in a really probably one of the hardest times in your life, and you deal with the process rather than being having a connection with the staff. You may be asked pre-prepared questions with pre-prepared answers to be ticked or crossed. Might be approached as just another case, just another number, just another target. And we found that a lot of assumptions can be made based on previous notes. And these, have often been miscommunications or misunderstandings. And there's no way to really build that dialogue or to, speak back to, reply to the psychiatrist who maybe wrote the letter where they've got something really, really wrong. I've never touched alcohol in my life, and I was put down as an alcoholic, for example. But I couldn't challenge that letter because it'd be sent to me, and I'll probably never be able to see this person again. There's no consistent contact that we found, as we had different people all the time, which, you can understand when resources are stretched or there's increased sickness, but it can make it really difficult for people who already struggle with trust. And I think it just makes you feel reduced to just your paper self. You can feel dehumanized. If you don't fit the boxes or fit the models or fit the KPIs that need to be reached, you can just feel even more worthless and quite abnormal, or maybe feel hopeless that you may not be able to get better actually in that service. And you can often feel that you're not understood. Next slide, please.
Thank you. Sorry, I just want to clarify. I saw a comment in the chat where I'd said about a drain on the public purse. That is how I was made to feel. I'm not saying that service users are a drain on the public purse. I'm all for service users. Yeah, that is how I was being made to feel. And I'll try and speak slower. So yeah, more on the impact. When compassion continues to be absent through the duration of an episode of care, and when needs are consistently not met due to other processes taking priority, the impact can contribute to existing distress as well as adding new harms. And this is something that I think is also not really acknowledged, especially if you continue to be in the system. So some of the impacts that we found or like what has happened, is the misdiagnosis, internalized harmful attitudes, which keep repeating over and over. If you hear it enough, you're going to then start to feel like that. Being left in unsafe situations, worsening health and reduced quality of life, guilt, shame, and self-blame. I definitely felt that one a lot when I was in the service. It even turned into feeling like I shouldn't be there because I felt like a drain on the public purse, because I was using too many resources. Hopelessness, re-traumatization, this internalized dehumanization. I think when I said at a meeting last week, I felt like I'd been reduced to a paper self, and that is how it was. It was people making judgments about me based on records that had come before from people who I'd never met, but that was what was then being presented to me, and that's how I was being perceived and treated based on. This belief that you are unworthy of help. I think when you're constantly getting knocked back, it's hard to then not feel like that. And yeah, we put this at the bottom because in mental health care, building rapport with someone, and yeah, making that connection can actually be the difference between life and death. But there seems to be a resistance to curiosity now, and we've been questioning that, I think, over the last few months. And we've sort of said, like, maybe that's because of time. Maybe now people feel unable to ask the questions as there is limited that they can do with the response. I mean, if the resources are strapped and you ask the question and you get an answer that you're gonna have to deal with, it's urgent and you need to deal with it, but you don't have the resources, that puts you in a very difficult position because you are then also having to fight the system. And yeah, it's just not ideal for anybody. But this, I said like a little bit before, I think that people struggle to acknowledge the impact of having less than ideal care, particularly non-compassionate care as well, that has re-traumatized if you do remain in the system. And that just adds another layer of complication to trying to get better. And I think there's this, we all want to like not believe that things can be so bad that people go to a helping service that they do end up re-traumatized, and like we fully understand that. But it's, yeah, I think that is also something that needs to be spoken about more, and maybe like that's definitely something we want to do with Not Safe for Treatment, keep opening up that conversation. Next slide, please, Paul.
So just thinking in terms of a lot of technology will be coming into the NHS, and also with the efficiency cuts. And we found that so far the efficiency measures have kind of been the opposite of what is needed, which is that compassion and that connection within mental health care. And we felt that so far the efficiency measures have actually added distance and have exacerbated the sense of service users and staff of this us and them, which actually is so not what we need. We need to join everyone together. We found that cameras are there, the Oxevision to surveil and monitor service users from a distance within acute hospitals. A lot of the decisions for people in secondary care are made in multidisciplinary teams without the service users' knowledge or say. People on community teams are being team held with no lead care professional. We're finding that the new open plan hospital living spaces are good. However, services seem to be staying within the office behind the glass, and so there's not that interaction between the patients and the staff. A lot of the triage questions or care coordination questions are prepared, and same with relying more on check-in calls rather than actual care coordination. And we're seeing that there's a real lack of professional curiosity, maybe as Leah was mentioning, because of that fear that actually we might have to do something with this person and we don't have the resources for it. And we're also finding examples of voicemails being used in community teams so that service users can't actually communicate effectively with their teams when they need them. Next slide, please, Paul. Thank you.
So yeah, this is sort of where we start to think about entertaining the possibility of change and thinking about what is actually important. I think there's a bit of trying to dream big in here as well. But we're all aware that the system is broken, but resistance to the counterproductive norms can be simple, personal, and seemingly small. we all know that compassion is a cornerstone of helping systems. It's also one of the cores of being human. It doesn't cost anything, it's free, and particularly for service users, I'd say it's really memorable in systems that can feel otherwise process driven and mechanical. I mean, I've talked a lot about the bad experiences, but the good ones really stick out now, maybe because they are so rare. But when you do get that interaction, it means a hell of a lot. We believe that compassion is renewable through intention, deliberate action, language, personability, and just genuine humanity in even the most broken of systems and dysfunctional of structures, even our trust. Pockets of compassion can persist and grow through individuals. We may not be able to change the whole system, but there is also big value in acting outside of it. So that is why we started Not Safe for Treatment. Community projects and starting local, community connection, peer-to-peer support, and just the safe sharing as well of lived experience, whether you are patient or staff outside of the system, opening up those conversations, I think can have a lot of benefit, whether that be for, your personal healing, to feel heard, or also for change. Basically, what we're saying in this slide is just don't let a broken system dictate the way that we choose to treat each other or destroy our own compassion and hope, because ultimately they'll always win. Fingers crossed. Next slide, please, Paul.
Yeah, so we just wanted to just highlight how important communication is across health and social care, but most importantly for mental health care. There's no x-rays, there's no blood pressure machines within mental health. Everything has to come through good communication. It's the main tool in understanding diagnoses, meeting needs, and most importantly, building trust. We're worried that this efficiency breeds assumption, and when communication becomes rushed and transactional, people often are going to feel more misunderstood and unsafe. And open conversation closes down, communication becomes less effective, and people are left feeling isolated when they actually need connection, clarity, and dialogue. And so many reports in coroner inquests or inquiries claim a lack of communication, which is one of the basics. And although, like everything is influenced by wider pressures, we do actually have more control over communication than most factors. Next slide, please, Paul.
We just thought we'd put a little bit in about action away from the system and sort of contextualize it to what we've done here. Not Safe for Treatment was literally born in Fenn's living room, probably out of desperation, over a cup of tea and a bueno, most likely, and out of frustration. But all it took us was once it got to the exhibitions, it was a lot of stress, but all it took us ultimately was some art materials. And I think we weren't actually expecting it to be as impactful, but also have as much benefit for people as it did when we started. And Fen, you can chip in here, but the things that we've found is that starting locally and doing something that is inclusive. I mean, creativity and art it can be made inclusive and accessible to all. We have always opened up our exhibitions and our workshops to absolutely everybody, whether they are impacted by it or not. There is no exclusionary criteria. Even with the artwork, all we say is that we follow like safe suicide guidelines. That is it. But you can share your experience how you want it, no censorship. There's the acknowledgement that navigating services can be difficult and upsetting at times and lead to isolation if experiences have been hard. And that was another thing we don't deny anybody's experience. Like, it's a very much come as you are sort of thing that has had the effect of reducing isolation almost inadvertently. We found that the process of creating allows for expression and catharsis, and then the process of then exhibiting opens up this space for achievement, but also communicating a message and conversation between artists and with viewers, which is why it sort of nicely linked in with the stuff that we were doing with the campaign because it is a way of getting a message across. And I think people will interpret art differently, but combining it with those experiences and also being able to talk about it, it was a way of, yeah, pushing for change as well. Oh yeah, look, I put it down there. We found that many use art as a way of expressing but also connecting with others, something that has gotten lost in the system, and exhibitions that combine art with activism. Feedback suggested that putting those in the same space provided both hope and motivation to involve in change. So that was another thing. What we did with our second exhibition is the campaign also exhibited things like their placards. We had a big magazine scrapbook thing of all of like the news articles and a loop of videos of like news reports and things. But people were saying that like we didn't realize there was this group that existed that's fighting for people like us, and putting that in the same space was like, do you know what, there are people who care, there are people who are trying to make change, people who do want to do things differently, and that is another way as well of reducing isolation, but also, yeah, keep building the hope. There's a little bit there about opening up networks peer to peer for understanding, but that was another thing. It's our exhibitions. I mean, I think you look at the wall and you think like some of this work is bleak, but we have our making table and we have the connections that are formed, and actually it's a really fun, enjoyable, open and connecting space where people can, yeah, make friends and also just be, have a cup of tea, make a collage if you want to, add to the exhibition if you want to, share your experiences if you want to, or don't. And yeah, just be accepted. I don't know if you want to add anything to that, Fen.
No, I think it's absolutely spot on. I think it was also just nice for people to come in and even if we changed one mind or got one person to consider, we had a lady come up to us and say, "Oh, I came in and thought this is really not for me." And she said, I started walking around and actually I was quite sort of averse and didn't want to look at it at first. But actually, she said, I've just realised how important this is. And she said, I'm so lucky that I've never had to deal with any of these experiences or with poor mental health. But she said it's really, really opened my eyes to what some people experience, and I want to, go back and tell my friends about it. So I think even just in those spaces as well, changing one mind of someone who may not have even thought about mental health, and just for it to just be in the back of their mind somewhere. But also people that have come in and thought, oh my goodness, I didn't think anyone else was going through this, and this art has just been a bit of a safer and more accessible way for me to connect with that and know that there are other people. So I think they're probably the biggest takeaways. And our guest artist as well. I mean, how amazing that they've maybe never done anything like this before. And they've taken those frustrations and that hurt and that misunderstanding, and they've created something absolutely incredible. And they can feel really proud that it's hanging up and people are coming to see it. Yeah, they should be mega proud. Next slide, please, Paul. Thank you. I think we've just got a collection left of some of the pieces from the exhibitions, a couple of bits of feedback from some of the exhibitions, something from our college workshop is there. And then the final slide is just with our website, if anyone wants to go and have a look at it. And we're more than happy to take questions if we've got time, Claudia. If not, we can bring them at the end. So whatever's best, Chair. Thank you very much, everyone.
Yeah, thank you.
Bravo.
Brilliant.
Absolutely incredible. You can see everyone. It really is such a powerful and honest. Thank you so much, Leah. Thank you so much, Fen. I just want to acknowledge how much your honesty has touched on people's lives in here today. Some people are telling us and sharing that they recognize that is such a honest way in also exposing what is happening in NHS. We have a few comments that I thought are really relevant for us to kind of say. Someone was sharing how these experiences that really resonate what they have seen as well as a professional and as a carer. if someone is saying, I am committed to try and work with as much positivity and belief in the desire of people to actually do good things as possible to contribute to meaningful improvements. I just wanted to share something that you said earlier that for me really has stayed with me, Leah. Being myself a young person that had a very difficult childhood. I was in Bolivia. We didn't have an NHS, but it is something that I thought was really for me spot on around your relationship with the NHS and how you at young age you see this side of the NHS. That's what I understood. This side of the NHS that is, oh, I thought it was here to look after me. And I think this is what's happening to a lot of us across the country. And probably I feel there is a collective grieving about what we see happening in the NHS, on how we are shocked to hear and see things that happen within the NHS, a system that's supposed to protect us and which we love and really care deeply about, but that it needs us to also scrutinize. So I think that in itself is a relationship that we need to explore as all of us. How do we go to this very important part of our lives and really scrutinize to make sure that really truly cares for all? And I'm sure that all of us have had somehow one bit experience which have felt let down. Now, just as we go into our next speaker, and I think everyone probably here has had an experience around data, the churning of data, the pushing of data. And thank you so much, Lee, and thank you so much, Fen, for sharing that, because we are looking at data before we see people. And that's why we wanted to have this session about compassionate support. I am so delighted that we have Paul here. I mean, Paul has been the engine, el motor, as we say in Spanish, behind all of us getting together. He might get us into trouble at some point, which I really look forward to in terms of exposing all of these issues. Because data
I haven't been a member of the Labour Party.
Data is huge, and we are an economic number. We are an economic number. This is what we're fighting against. So we're so happy to have you here, Paul. I forgot to say at the beginning of the intro, because I got too excited, we have in this section now with Paul, and then at the end, we're also going to have an area where we're going to, all of us, share our thoughts and ideas on how we think community mental health, like the fantastic program, an initiative that Leah and Fen has shared, can work collectively across the country. Paul, you are our next speaker. I think most of people know you, but I'm going to make sure that we have an introduction. So Paul, just as we hear from Paul Atkinson is going to talk to us about the undermining of human relationship in NHS talking therapies. Paul is a psychotherapist. He helped set up the free psychotherapy network and has been involved on and off in mental health political activism since the 1970s. He currently offers free therapy in his local community centre in Poplar, London, and he helps convene the Mental Health Action Group. He also walks the medieval landscape of Kent as often as possible, and he is a dear comrade of mine. That's what I need to add that to Paul. And a lot of people. Paul, we're so happy to have you here. Please inform us even more and make us go hungry, ready to fight. Go on, Paul.
Thanks, Claudia. I'm going to talk about talking therapies, which is it's certainly going to be a drier presentation that we've just had from Fen. I just thought it was absolutely fantastic, and thank you both. I've been involved in the politics of talking therapists for a very long time, more or less since IAPT was introduced in 2008, when many of my colleagues and I were really quite shocked at the process of sort of transformation that therapy went through with the introduction of IAPT and what has later been called talking therapies. When I talk about talking therapies, and particularly about the statistics that the service produces, I'm often accused of being very negative, very, very critical, and I think I am, and I'm going to be again. But I want to say that this is not criticism of the practicing therapists within the NHS talking therapies. system. I have not worked for the NHS myself. I know a lot of NHS therapists who clearly are doing really excellent work and are motivated by exactly the same principles and dedication to people's mental health and social change as I am and my colleagues in the independent sector. What I'm talking about basically is talking therapies as a system. I'm talking about the systemic nature of talking therapies, the way the service is managed, the restrictions on it, and the kind of ideology behind talking therapies, which to my mind are clearly more or less an archetypal example of neoliberal policymaking. I know the term neoliberal has got a bad press among many people. I'll say a bit more about that later. I want to talk about three aspects then of talking therapies. The first is who gets what kind of therapy for how long. The second is, I'm calling it people, not data. And I want to say a bit about the work that's being done on the introduction of AI therapy within the NHS as a kind of third section. So I think that one of the most striking features of talking therapies is how many people in England who are experiencing common mental health difficulties don't get therapy from the NHS. And I think we could say that systemically, in some ways, talking therapies is a system of denial of care. Last year, 2024 to 5, nearly 2 million adults were referred or referred themselves to the service. A third of these referrals never received any therapy at all. That's about 600,000 people. In an ICB like Greater Manchester, half of the 150,000 people who were referred or referred themselves dropped out without entering any kind of treatment. On top of that, in most of the ICBs, half the people who start therapy don't finish it. In fact, more or less half the people who start therapy do only one session and drop out. So what this means is that basically 2/3 of talking therapies referrals drop out before they finish a course of treatment. Last year, I wrote to every one of the 42 ICBs in the country, offering them some of their own data, which is published every year, every month, every year in reports on talking therapy. I offered them an analysis of their own data for their ICB, and asked them, among other things, why is the dropout rate so high? And what happens to people who drop out? Do you know what happens to people who drop out? 2/3 of your referrals drop out. They've approached you, obviously concerned about their mental health. What happens to them? I mean, out of the 42 ICBs, about 4 ICBs replied to any of the questions we asked them in any detail. The majority didn't reply at all. But those who did reply did offer some kind of explanation of why so many people sort of never start or drop out. And also in reports from other sources, the same kinds of issues come up. So, for example, people don't begin therapy or not offered therapy because their condition, their mental health condition, is too severe or too complex or too chronic. They're also not offered therapy because their condition's too mild. They're not offered therapy if they are if they have a history of substance abuse, misuse, or addiction, or at least are currently using drugs or alcohol or other substances. They don't get therapy if there's an immediate risk of them taking their own lives or harming themselves. And they don't get therapy if they've previously been in treatment or in treatment elsewhere. There are statistically the other issues. There are other obvious issues, like I think neurodiversity is an issue for talking therapists. Minoritized communities, ethnic minorities, social class, disability. These are all categories of referrals that are less likely to get access to talking therapy. There are people with limited English. There are people with limited digital skills. And a major category in which that's not represented in talking therapy access figures is men over women. The vast majority of referrals who get therapy are women. And then why do people drop out after they've started? Well, partly it's the waiting list between the first and second session, because currently talking therapists commit to people getting their first session within 6 weeks, and almost all the ICBs succeed in doing this. But then there's often a really long wait between the first and second session, a wait of, I don't know, up to 16 weeks. Some people are on waiting lists for over a year, I think. So, I mean, we really have no way of really adding up the waiting lists in different ICBs at the moment. So we're reliant on subjective reports. So my question is, what happens to all these people, who have said that they're in trouble, that they want help, who can't get talking therapies? And so, secondly, looking at the kind of therapy that talking therapies offer, I think this is one of the reasons that people do drop out, either having heard about what their kind of therapy they're likely to get, or having the experience of a first or maybe a second session, and decide really that they're not feeling met, or they don't feel that they're known by the type of therapy that they're being offered. So most of the therapy is behavioral. About 75% of the therapy that's offered is behavioral. Every course of treatment is short term. The average
I think Paul, I don't think we can hear you. Or maybe it's just me.
Can
Can
you
we
not
hear
hear me?
Paul? Oh, yeah, now we can. Yeah, thank you.
Yeah. Is that better? Have you heard nothing of that then?
Hello, we're just hearing you now. No, just a joke. Maybe just 2 seconds. We were just being very compassionate and just pretending to be listening. No,
All right.
just about 2 seconds, Paul. Thank you.
Okay. So did you get what I was saying about the number of dropouts?
Yes, yeah. And
Yeah.
then yeah, thank you.
Yeah. Okay. So I think partly what's going on is what's offered, the behavioral therapy that's offered, or the emphasis on behavioral therapy, which is the commitment that talking therapies as like made right back in 2008 when it was set up, just doesn't meet so many people, and 8.4 sessions for a course of treatment for a therapist like me who has a humanistic and then psychodynamic training and expect to see people for several months and several years. I mean, I personally don't understand how you can get very far with not everybody, but with so many people in terms of, kind of exploring who they are and their history and their language about what's happening to them and what their experiences is their pain and so on. Counseling for depression is the nearest to a more relational kind of therapy that I'm used to, and that people were used to in GP practices, I think, before IAP was introduced in 2008-9. But only about 11% of courses of treatment are actually counseling for depression. And I think the kind of tick box exercise of assessing every session or assessing yourself in every session, I think that must be really difficult for a lot of people to take seriously and imagine that they are actually being related to and that there is some kind of human relationship being formed. So my second point is just how dedicated talking therapies is to its data, to collecting data, as its evidence base, which of course is the foundation of its continued funding from the government. Thatcher said there is no society. In many ways, there is no society translates as there's no need for compassion. There's no need for empathy. The market will take care of relationships. The market will take care of people's problems. And talking therapies was very much set up as based on a kind of ideology of privatization, cost efficiency, and the measuring of output and results. And I think as the whole project, the whole Thatcherite project, has been increasingly stumbling and creating cumulative crises in our society and so many kind of Western societies, crises like economic and social crises, climate crisis, and I would say the mental health crisis that is talked about in the press so much these days. I think as something isn't working in what I would call the neoliberal project, and things are getting worse and worse, thinking, for example, in terms of the inequalities of wealth and income, then I think so much policy making over the last 3 decades has really been about the need to patch up the failures of the market and the system without really changing basic understandings of what society is about and how societies work well. And I think talking therapies is a really excellent example of that, trying to fix something without really changing the basic way of understanding human beings and what we need from each other and what makes us feel kind of happy, relatively happy, creative, aware of ourselves, our own needs and other people's needs. So I mean, talking therapists, it just gathers a massive avalanche of statistics every month and every year. And they record statistics about each person who's referred in terms of their ethnicity, their age, their gender, religion, sexual orientation, level of social deprivation, diagnosis, employment status, as well as the type of therapy they're given and the outcome of the therapy. So there are millions and millions of data points in the stats that talking therapy produces. And yet, at the same time, their evidence is, I think, more or less completely ignored by themselves as much as by everyone else. So in the open letters that we sent around, for each ICB, we sort of challenged whether or not they'd met the 3 requirements that the government sets for talking therapies, which is their recovery rates, their waiting times, and targets for the percentage of people who it's estimated will be suffering from common mental health problems. What percentage of them actually gained access to talking therapies kind of each month? None of those requirements are met. They have a 50% recovery requirement. They calculate it by the percentage of the people who finish a course of treatment who recover. They don't take into account the number of people who've dropped out, even people who started therapy and then dropped out. As I said, waiting times, they've certainly fulfilled their 6 weeks waiting list for a first session, or many ICBs have, or they have on paper anyway. But the gap between the first and the second session seems to be where they've moved that problem of waiting times. So it's very strange to be declared to start therapy and not get a second session for weeks or even months. It just does not compute. Does not compute for me. Almost every ICB totally disputed the analysis of their data. They didn't recognize it. They thought it was more or less abusive to have accused them of their dropout rates and not meeting their access rates and so on. So it's as if it's completely, their data is actually completely irrelevant in terms of actually looking at how they're doing as a service. And for so many of them, on so many occasions, the data's simply used as a sort of propaganda front. We've seen 1.8. We have had 1.8 million referrals this year. Recently, I might just show you this. I've got a couple of slides. I'll try putting this one up. But recently there was a report in the Telegraph that Streeting and whoever else in the government is now worried and complaining about too many people are not working. They decided that 9 million people should be in talking therapies in order to get people back to work. I mean, this takes me back to the 2016-17 campaigns that we had against the back to work policies of the DWP not so long ago under Cameron and so on, where IAPT therapists were being used in job centres or GP practices specifically to get people back to work. Well, this is what's happening now. This is exactly what's happening now. It seemed to go in abeyance. I don't think it did, but it's really back with a, with a bang. And why are people not working? That is not the question that is being asked. Why aren't they working? Why don't they want to work? It's assumed that there are all kinds of problems with the individuals, or a laziness, or I don't know, lack of the right kind of education and so on. But what's not talked about is the kind of society we're living in and what work is like in this society, and particularly for young people, the precarity of work, the sense that there's no hope of getting any housing, and so on and so on. But anyway, in this article, there's a classic use of stats that is so often used in relation to talking therapies, where the number of people referred to NHS talking therapies has increased by 26% since 2018, and more than 7 million referrals in the 3 years to the end of 2025. Well, yeah, there were 7 million referrals, but 2/3 of those referrals dropped out. There weren't 7 million people kind of accessing therapy and doing therapy. So the idea that 9 million people are going to get some therapy and get back to work is just complete and total fantasy. And I think this is very much the way the stats have been used. It's talking therapy is like a very separate organization within the NHS. It's not accountable to an independent body. CQC doesn't scrutinize talking therapies. It seems to have its own managerial system, and it doesn't consult its clients or patients or referrals, whatever they want to call them. And it doesn't really do feedback, but a very small proportion, something like 1% of people who have finished a course of talking therapy treatment are actually followed up after 6 months, between 1 and 2%. So we don't really know what's happening to people after they have had therapy. AI therapy. I've written a couple of articles on AI therapy, so do have a look at them. They're on the Mental Health Action website. The digital therapy, digital apps, the digitalization of talking therapies has been going on for a really long time. In 2021, the American Psychological Association estimated that there were between 10 and 20,000 well-being digital apps, which people are using more and more of. But I think the real sort of gold standard of AI therapy is the capacity to produce autonomous therapists. So, I mean, at the moment, AI is being talked about in the NHS as an aid to talking therapies, an aid to the therapist's administration, or an aid to the assessment system. 50% of ICBs use Limbic, which is an AI assessment tool for talking therapies. And there are companies that are downloading recorded sessions to discover what is successful, what kind of words and phrases that therapists use are more successful, and they're being used as sort of teaching for teaching therapists what works and what doesn't. But the gold standard is to have conversational AI, conversational agents who actually will do the therapy work with very little more than supervision, maybe from therapists. And it's the private companies who are providing NHS talking therapies who are most advanced in using their patients' recorded sessions for machine learning, and are actually working at the moment on producing AI conversational agents that can become, therapists for NHS patients, but also for mental health services all around the world. And most of this work is being done by global companies collecting the data, processing the data, developing the algorithms and the software. It's the global data companies that are doing the actual number crunching and the production of these AI agents. And one of them is ISO, a firm called ISO that started in Cambridge. It works. Last year, it had 7,000 referrals within the NHS. A couple of years ago, it had 15,000. I think that was to do with COVID. And to quote a guy called Andy Blackwell, which I'd like to show you a 2-minute clip of in a second. In order to develop AI conversational agents that can conduct a therapy session independently of a human therapist, the company says it has so far analyzed over 2 million therapy language events, a core requirement for the conversational agent's large language models. This is its professional training. So in his 2020 TED Talk, Andy Blackwell, one of the senior therapists at ISO, he offers this extraordinary and so on. So I'll just show you the clip that demonstrates how they're
Thanks,
doing
Paul.
it.
We use the same technology, it's called deep neural networks, to take the language that's expressed in therapy and to translate that into a simple therapy barcode or fingerprint that we can analyze readily. What you can see here in this line is a 1-hour session of therapy between a therapist and a patient. And the colors signify different types of dialogue that are occurring moment by moment through the session as interpreted by the artificial intelligence. At the beginning of the session, the computer detects a greeting. The therapist says, "Hello." Then for a few minutes after that, these green elements show us that the computer is detecting chit-chat or simple non-therapeutic language. If it were here in Boston, it might be about the traffic. About 8 minutes into the session, we see these pink elements. That's where the computer has detected that the therapist is starting to use structured clinical language and a range here of therapeutic techniques. In this particular session, it detects that the therapist is using something called cognitive reattribution, which is a technique that therapists use to help patients understand that they themselves may not be the root cause of all the difficulties they are experiencing. About 40 minutes in, we see more chit-chat until the end of the session when the therapist says goodbye. After each session, the patient reports the frequency of their symptoms using those questionnaire-based rating scales. And that enables us to study the relationship between exactly what's happening in the therapy session with subsequent improvement in symptoms. We've now studied over 20 million therapy language events, and we're starting to see some really important patterns. A simple example is that we've found, at least for this form of therapy, that effective care seems to be surprisingly businesslike. Therapists set an agenda for every session. They have goals for the time that they spend with patients. They review homework tasks that they've...
Yeah, and he goes on a bit later to talk about how empathy is not really a therapeutic vehicle. and gets in the way of the business of the therapy, which is it's just really fascinating to hear it heard. And AI, empathetic AI, a massive amount of research and money is going into teaching a form of empathy to AI agents at the moment. So I think the future, at my most depressed, really, the future of talking therapies in NHS, in the NHS, and I think around the world, in as much as the talking therapy model has been adopted by all kinds of countries, Australia, Canada, parts of Scandinavia, and so on. I think the whole emphasis on CBT and behaviorism has really opened the door now to this kind of automated therapy using AI. And I mean, we probably all had read examples of how AI therapy can go extremely wrong in people's hands. So I'm going to stop there with that kind of rather doom-laden note on what's happening to compassion and empathy within the talking therapies. Thank you.
You could see, oh, Paul, it's difficult to come back to that or from here when you say, thank you so much, Paul. And you can see people clapping and hearts. I just want to add, before we go into our collective group, I think we have learned so much throughout today's session. Compassion really is, I feel, especially under Keir Starmer's government, is the least of, it's not a priority, it's not on the priority list, and it certainly cannot be seen as such. I want to also add that you may have seen there's a new immigration white paper proposed by Shabana Mahmood, which punishes people who have received, who have accessed welfare state benefits, and they will be receiving an additional 7 years, and in some cases up to 10 more years to receive the residency. Why am I linking this up? It's because there is a real punishment for people that are not contributing enough. And I think what Paul was saying to me, my reading of this horrendous, not empathetic system is that they just want to get everyone back to work. And as someone was saying on the chat, I think it was you, Rathi, that said, I just copy the comment because I think it's really important. Rathi, who's here today, is the chair of the Socialist Health Association. She said, I work in the humanitarian sector and we're consistently referred to a private sector talking therapy provider for a minimum of six sessions of 30-minute session each. I tried it once and it was a sort of like a life coaching. Many colleagues have felt gaslighted by techniques. Now, something that what Paul was saying around the way in which talking therapy works, a lot of people we don't know if all of the people that are in the system are therapists that receive sufficient training. People are being pushed. I was a mental health, so when I was training and I was working in an NHS GP surgery, I was encouraged to tell patients to rethink their rating if they said that they weren't improving. I was encouraged to tell them that they should say that, yes, they're improving, because otherwise we will lose the contract. I mean, I'm happy to say to you that I did complain at the time and I thought this was abusive. It's re-traumatizing. But this is the whole purpose of a system that really wants to see progress in data, but actually doesn't stop to think and of the healing of that person. And just to add as a last point, as we go into our next section, I feel we need a whole new session, a whole new conference on the underemployment of mental health therapists in the sector, because there is a lot of colleagues, there are a lot of colleagues that don't have jobs because there's not enough funding for mental health therapists or counselors in the NHS. And a lot of the people that are providing IAPTs or now talking therapy might not have had all of the years of qualifying training that many of you, perhaps colleagues that are in here, have had. So as I feel like another topic. Paul, thank you so much. I went on a bit with my comment there, but it is depressing. I have shared in the chat, so all of you can see what Paul was telling us. I'm going to copy again his great articles. And also I'm going to share now the dashboard, which when Paul and I met, it felt like a match in heaven, because I've been talking about this back from my little corner. And then I come to Paul, who has a massive knowledge of this subject.
Too much. Too much
Match in
data.
heaven. So you could, all of us can see the letters that we have sent to our ICBs. You can see as part of the Mental Health Action Group. You can also see the board that has the live data, which Paul was referring to in terms of dropout rates. And as Paul said earlier, I took note of your question, Paul, you know, what happens with the people that drop out? Where is the aftercare? And I feel that I'm just going to conclude with this before we go into the next section. I do a lot of activism in terms of young people and support for them, because I guess I relate a lot in my youth, having such a difficult childhood, traumatizing, and to the extent quite abusive. But I'm very fortunate that my community supported me and helped me. I cannot imagine what a parent or a young person who's on a 3-year waiting list for mental health support can feel when they hear that there is high levels of dropout rates, potentially public funds not being spent in the way that is meant to, and then having hundreds of thousands of sessions that go unused when we have such a long waiting list of people. So I cannot imagine what that young person must feel when they find this out. But it's important that we bring this up. Sorry, I didn't copy the links here. I just sent it to Terry in a private message. Sorry, Terry. And sorry all. I'm gonna put into to everyone's chat. Okay. Shall we have maybe like a 2-minute comfort break, Paul? Because it feels like maybe we need to get up for just 2 minutes and then come back at 12:30 sharp, just so you can get up and maybe get water, coffee. I see some of you already leaving your chairs. It's much needed.
Okay.
Go for it. We'll be back in 2 minutes, where all of us, we're going to open the mic so all of us can chip in, and then we take action from today. Thank you, everyone. 2 minutes. There are the links. Is that okay? Yeah? Lovely. Right. Okay, so we have, so you can, when you're back, you can open your, I wonder if it might be worth going into groups, because it's such a large, we're 100 people in the room, or we can just all, what will be people's suggestions? Should we go into little groups, although that might be difficult to manage, or wait 1 second. Let me just check.
Budget, I think that little groups would be far better, because we've got 90 people here.
Great, and then we can, yeah, I can
Are
create
you
maybe
able to
3
do
groups.
it? Are you
Yeah,
able
let's
to
do it.
breakout
Yeah,
groups? Yeah.
So I can create
10 something.
four breakout rooms.
I prefer not,
10.
actually, because what I think's great is I feel terribly, terribly isolated as a mental health carer in Hampshire. And it's great to hear that there's other people. And so that's the flip side of going into groups.
So if we do 3 groups, there will be at least 30 plus people in each group.
Are you happy with that, Shirley?
Sorry?
Are you happy with a group with 30 people?
I don't know.
And then we come back.
Or do you want smaller or bigger?
Well, I don't know. I mean, I've actually got to shoot off at 1:45 because I've got to go to the chemist before it shuts. But
Right. Okay. I think, can I maybe just, for people that are here, could you maybe just say thumbs up if you feel that breakout rooms are good, or you prefer one big? So breakout rooms? Yeah? Only some people? Okay, not many. Okay, so let's just leave it then open because a lot of people are not in agreement with that. Okay. Yeah, I can see. Do you prefer a bigger group? Just a one group?
I think let's just wait until everyone's back. Huh?
Yeah.
Is everyone back yet? I don't know.
No, not yet.
And
Well, it feels. Hello, Olivia. You wanted to say something, Olivia?
I was just thinking by the time you organise it,
Yeah,
to
exactly.
go into groups, and a lot of
Yeah.
people haven't got their cameras on.
That's right.
I don't know why that is. You might find that, I mean, 30 is still quite a big group to have a personal exchange, isn't it?
You're right.
Better
Yeah.
just to hear some people say things and hope that in future there'll be an opportunity to do
Okay.
smaller. Yeah, that's what I
Lovely.
think.
Thank you.
I think we were quite surprised how many people actually wanted to come to the meeting, and I'm sort of thinking that we probably need to do more meetings and develop what we're involved in. We didn't really think about breakout groups. I think
That's
it's
right.
hard to go into it without having thought about it, and
Okay.
people need to feed back, don't they, from groups and so on. That's
Okay. Let's just stay as
so
a one
can we
big
just
collective.
put up with what the limitations, I think, of people just raising
Absolutely.
points? Yeah.
Yeah. I was just only thinking in terms of precisely that, like,
Yeah.
what would be good for us. But let's stay as a big collective, that's when we're more powerful, right? All of us together.
And let's
Right,
face
let's get it started.
sorry,
Lorraine,
wants to say something.
I was only going to say, let's face it, we've been on a roll with technology so far. I think the risk is too great.
Excellent. Right. Okay. So we have just under half an hour for this section. Welcome, everyone. Whoever coming back. The microphones are, you are able to open your microphone. Just maybe raise your hands if you want to speak. This is an open session for all of us, so that we can share our experiences and ideas about how to develop more compassionate and relational ways of working with people's mental health in the UK. It's been an incredible session so far. For people that want to speak, just saying, mindful of being as as brief as you can, but of course, I don't feel rushed at the same time. We'll keep that balance. Shirley, thank you for being here, and yeah, amazing. So looking forward to hearing you all.
Well, I've got loads of things to say, but I'm just going to say one thing just to keep it brief. I'm a mental health carer, and the person that I care for has a diagnosis of, well, we don't really like his diagnosis, but it's paranoid schizophrenia. It's such a horrible term, isn't it, with associations that one has. And he's living in the New Forest, and he doesn't have any counselling support. And when we've asked for it, we've been here about 15 years. There is no counselling support for him. It's just unbelievable. I go to MP surgeries. The thing is, I've fought for mental health for years, ever since he's not been well. I find it terribly stressful on myself. I feel I'm about to have a sort of crisis when I'm trying to fight for mental health support. It's unbelievable. He was given this person, and when he asked her what newspaper she read, she said that she didn't read newspapers, but sometimes she read The Sun online. So it wasn't terribly suitable for him as a kind of support person. And also, when he was seeing her, was doing all the hard work. So I just wondered, in terms of his rights, isn't he entitled to have some sort of support for really uncomfortable symptoms? I mean, he does do a lot of his stuff online, and he does this, I can't remember what you call avatar stuff. He did he did a short course using avatars, which is just brilliant, which is run by UCL and King's. But it's just about it. So I just wonder what the rights situation is regarding that.
Thank you. I think what we could do is I mean, we'll have probably the least interventions possible, so then we can hear from everyone, and maybe we'll come back with answers at the end. Is that okay, Paul, and our team in Mental Health
Yeah,
Action Group? Yeah.
it
Okay.
immediately
Brilliant. So then,
raises things that I'd like to say, but let's hear from people.
yes, brilliant. Thank you, Shirley. Judith. Hello, Judith. Welcome. Can you
Hello.
open your mic? Okay, great. Yeah,
Yes,
we're here.
fine, thank you. Well, I've got a number of points I'd like to make, but I'll stick to just one because of the timing. I would like to see the resumption of triangle of care happen. This was adopted when it was first publicised in 2010 by all the mental health trusts in the country. And since then, it has lapsed because people don't want to implement it. Being adopted does not mean implementation. They adopted it. They did not agree to implement it. But all of them agreed it would be useful. The triangle of care means there is collaboration between the service user, the family member, and the professional people, whether that's a therapist, whether it's a psychiatrist or whatever. There's active collaboration in the interests of all three. It's been forgotten because it needs to be implemented, and you need to have a staff member who's really dedicated and committed to it, and then make sure it's actually happening. But that would be a big step forward, I think.
Thank you so much, Judith. Jane, and then we have Lorraine.
Oh, hi, I'm Jane Wilson. I'm a family therapist, Unite member and member of Save Lewisham NHS, working in the NHS for 25 years now, in 26 years actually this year in South East London. And I just wanted to pay tribute to Shirley and Fern and Leah for sharing their experiences, because I think as a clinician, it's really, really important to just hear the voices of service users and carers. I wanted to bring in a little bit of information. We're talking about alternatives, and I wanted to talk about open dialogue, which some people might have heard of, which was developed in Finland in the 1980s, working with people that were presenting there with a diagnosis of psychosis. And just to let people know, there's a current major mental health research trial going on in the NHS, 5 centres. It's called Odessi, and nobody can ever remember what all those initials stand for. But it's due to report this year in April time, very soon in the Lancet, and it's going to be comparing peer-supported open dialogue with treatment as usual. And just briefly, as I can do, what's wonderful about open dialogue, it's a way of organising services which emphasise continuity from the first point of contact, working with the person and their network, whoever that might be, and open to meeting with people wherever feels right for them, with open discussion making, open discussion and decision making. It's also a philosophical and ethical approach to distress, which sees mental health issues as very much a response to difficult life situations, sometimes trauma, and that there is real meaning in people's unusual experiences and what might be called symptoms. And thirdly, it's a set of practices and a way of being with people and having therapeutic conversations, which emphasise things like transparency, collaboration, respect, and relational care. And we're really, really hopeful. It's sounding good that the results of this trial is going to be very good, and it has the potential to transform mental health services, because we know that the evidence base is what is listened to by what was NHS England, the government, and NICE. But it just gives me some hope that we will be able to transform mental health services into something that is humane and compassionate and healing. And certainly my experience of working in this way has been absolutely fantastic. It's the best working experience that I've had in my life. And the feedback from service users and carers has been that this is something very different, very meaningful. And we often hear people say, we've talked about things that we haven't talked about before and we really needed to talk about. So I just wanted to drop a little note of optimism, that hopefully these results will potentially bring something better to the NHS. Thank you.
Thank you so much, Jane. Really helpful. And everything, as we know, we're recording the session, and it's going to be on YouTube next week. And also the chat, that people that are engaging in the chat, please know as well that you can save the chat, because there's a lot of information being shared. Thank you, Jane. We really appreciate your sharing that with us. We have Lorraine and then Edith.
Hi, I'm Lorraine. I'm part of Mental Health Action and the subgroup of Talking Therapies group. Sorry. I've been lucky enough in the past to work in a trust where talking therapy hasn't all been about CBT, and also that really there's never been that much emphasis on diagnosis. There's been much more interest in how that person arrived at the state they decided to seek help, what might have been the factors, and also I mean, at one stage, I was even allowed to see somebody for 7 years until a clinical psychologist took over in the team, and we were told that a year was the absolute maximum, which seemed a terrible shame. What's really shocked me of late was I had some connection with an acute trust and actually visited a ward where I hadn't been in a ward like that for more than 20 years, and the shock of seeing the total lack of compassion, the total lack of curiosity. And although, the triangle of care is talked about, it was really something on a piece of paper rather than anything meaningful. And I think the only way things are going to change in the future is that, we really push the service user voice and the carer voice and insist on that being heard to bring about some change. I could say so much more, but I know time is limited, so I'll stop at this stage and let other people get in. Thank you. But thank you so much to all the contributors today. It's been really, really good.
Thank you, Larry. It really has. It really has. And I think this is probably the first of many of these sessions. Edith, thank you.
Hi. I'll try and be quick. Another little gem of hope at the Maudsley Hospital in South London, where there is a small hub of the Institute of Psychoanalysis in South London on the campus of the Maudsley, and they've made quite a good contact with Maudsley, so that psychodynamic thinking is becoming more acceptable again after a very long, hard time. And there are 2 units, one the self-harm unit, inpatient and outpatient, and one the type 1 diabetes unit with people who are having eating disorders, which can be fatal with diabetes. And these 2 units have formed teams, have been allowed to form large teams which meet regularly. Psychiatrists, psychologists, psychoanalysts, psychotherapists, nurses, medical doctors from the units that are relevant. They come together on a regular basis to discuss the best plan for each patient. Psychodynamic therapy for 1 year is allowed for each patient. On the wards, there are activities that are helpful. And there is research going on about these activities, which so far are proving that they have a large impact on hospital referrals, on readmissions to hospital, and are actually lowering costs for the NHS.
Thank you so much, Edith. That's really, really helpful. It's good to also hear, isn't it, those gems of hope.
Yeah.
Thank you so much, Edith. We have Stacia and then Lisa, and then I think then we're gonna wrap up as to where we go next after that, especially hearing all of your input. Stacia?
Stacia,
Welcome.
thanks.
Stacia,
That's
sorry.
okay, not to worry. I'm going to put my camera on, but when I did it before, I lost all connection, so I'm a bit worried. Well, if that happens, take the next
And you come back.
participant.
Of course,
I'll
I'll wait
have
for
a
you. Of course,
go.
okay.
I'll
Thank
have a
you,
last
Stacia.
go. Hello, there's the light. Right, thank you. I'm a clinical psychologist working nearly 40 years in what used to be called community mental health teams and on wards at Southwest London, St George's. And I wanted to address the question of I'm sorry, I don't remember the name of the speaker, who I believe is the mum of a son who was diagnosed with paranoid schizophrenia, and she was asking what should be on offer to her son, if it was a son, sorry. And it made me think of oh my goodness, the very, very often not so nice guidelines. But with respect to people who break down with psychosis, there is something, and please don't shut off the conference because of saying this, but there is a treatment called CBT, yikes, for psychosis, though.
Yeah.
Very specially for people with
Absolutely.
psychotic problems. Hello, Shirley. Thanks.
Yeah.
Now, I've trained in that. I'm very, very psychodynamically informed, and I'm not, I've worked integratively all my years, and with a wonderful psychiatrist who didn't want me to discharge people after 2 or 3 years, keeping people off the wards and all the rest. Sorry, I'll be brief. But CBT, it's for short, is the most integrative and narrative inviting of the person who's suffering's narrative. It's the kind of CBT which is most like something psychodynamic and not all manualized or very short term. And that's the other thing. From the last time I saw the NICE guidelines, I think called for schizophrenia, I believe, but there was no limit. There was a bottom limit. It had to be minimum 10 sessions, and there was no upper limit, which is just something to say if some people don't know about it. Thanks. I was also going to talk about triangle of care and open dialogue, but I'm glad other people are aware of those extremely important ways of treating and trying to help as best as possible. Thanks.
Thank you so much, Stacia. That's really helpful as well, and good that you got good chat out. Sorry. Can you hear me, Stacia? We can see.
Yeah, now I can. Thanks.
Okay, I was saying thank you for that. It's really helpful to hear, Stacia. Thank you. We have Lisa. Lisa, can you hear us? Yeah, great. Thank you.
Yes, I can hear. I am not a therapist at all. I'm a member of the public who is interested in Keep Our NHS. And however, there's two things I want to say. One is, start off by saying, all my life, due to allergies, asthma, and goodness knows what, I have determinedly, assertively pushed and argued with doctors for help. It has been absolutely horrendous situation, and I find others in the same situation. So to me, what you're all saying about lack of care, lack of empathy, you only find a few people in the NHS which I found throughout my life, which is absolutely appalling. But I have had help from very, very capable, nice doctors and people. Now, I'm going to say hemochromatosis because I was diagnosed with depression, as have a lot of hemochromatosis patients, because it loads iron into the brain. You can laugh about it, but it does, into my frontal lobe and into other parts of the body. Once I was helped with the venesection from iron overload, the brain fog, the anxiety goes. Once I start to load iron, it starts again. Other people that have been on the Hemochromatosis UK Zooms have also been diagnosed with depression. This is not a correct diagnosis. So they've been putting people on tablets you don't need to put them on. Secondly, so this, I think all the diagnosis needs to be looked at. And I do realise there are lots of categories to mental health, and that is probably a very minimal one, because there's categories I will not even know about it because I am not professional in this area. The other thing is I was in a group with, I can't really say who, in York, and there were scientists there putting hats on people's heads at university. And this is about A1, and I'm just thinking completely out of the box. Like, I've got all the wood, not a single tree. The scientists are putting hats on people's heads because in a police interview, if you do that, people that have committed crime, you can see parts of the brain where they're lying. And I'm just thinking, we've gone into NLP and all kinds of psychological things like this. And I'm just wondering, I'm not saying lying about these people, but looking at the A1 and the way it's being used, and obviously scientists have looked at this and they've really looked into the brain. I am just wondering if that's what they're trying to use on these A1 programs, but I can't see how it would work when they're looking at the different colours and different parts of the brain, then trying to flip the brain, because they're finding all kinds of things with brain at the moment. That's me speaking from a non-professional, not knowing person. And I'm just wondering if this is what's going on. And when we put in data down about patients, me, it's like a communist state, not like a proper NHS or therapeutic state. So I'm just wondering if something like that's happening. I can't understand it. Sorry, it might not be helpful, but it might be.
Yeah, thank you.
It's very helpful. Thank you, Lisa. Paul, do you want to come back with, because we have now just under 10 minutes to conclude our session. It would be good to wrap up with the comments that we have heard. I just wanted to, before that, maybe very quickly, some people that maybe disconnected, their connection broke and then they came back and can't see the chat. I think we can share the chat afterwards for those asking, concerned that they lost all the information and data shared on the chat. We can share that, can't we, Paul? I'm pretty sure we can.
Yeah, we can. Yeah.
We'll look into that. So don't worry.
Yeah.
We're going to send that by email to those attending in here. Thank you so much. Paul, shall I pass on to you as to how we wrap up in terms of actions that we take from the comments that we have heard and how we take it forward? It feels like we have a few sessions in the lineup that we need to come back to and probably hear more from the project. And can I just say very briefly, a few people just wrote to say they loved my earrings. Can I just say thank you? Thank you so much for saying that. And there is a lot of, actually, there's an emotional meaning with my earrings. It's indigenous, Bolivian indigenous earrings. And that's how I feel very loved and cared for as well. So I'm doing my own self-care. Thank you. Thank you. I wanted to share that. Paul, back after my earrings, back to you.
I think one of the things I want to say is overall is to me the most striking thing is just the lack of space for relationships to develop, whether it's between therapists, professionals, mental health, carers. But I think it's the lack of emphasis and appreciation of longer term relationships that just has such a minimal sort of space in our mental health system. So I mean, I in Tower Hamlets, where I do free therapy, I see people who are basically been, they've been diagnosed with bipolar or schizophrenia, hearing voices, whatever. And apart from seeing a psychiatrist every 3 months or 6 months, there's very little contact, very little human contact with mental health services. And it's just pretty clear that to be in a kind of therapeutic relationship of some kind on a regular basis over a period of time is just hugely beneficial to people, as well as being enormously beneficial to oneself as a sort of therapist. So that's the heart of the matter for me, is the lack of space for long-term relationships in which people really can get to know each other and sort of support each other in the way that people feel the need for support and for thinking about what's going on and what might help. As far as where we go from here, I'm not sure. I mean, a while ago, I think there's enormous interest in mental health. I think it's very, very difficult to gather people in a sort of organized way to campaign around mental health. And there's some good reasons for that, because people who are suffering from various mental health conditions, they're so isolating, and people tend to be so isolated. So I think sort of any opportunity or any encouragement for us to get together and to talk about our experience and think about how to campaign for a better, more humane mental health care system is just really important. So that really is what mental health action is dedicated to. I mean, we've got quite a few professionals, retired professionals, psychiatrists as well as psychotherapists and carers, members of family of people with mental health conditions. There are 3 or 4 mental health service user groups around the country that participate in our meetings. So, but there are enormous gaps in what we could do. There's basically so much to do because the mental health system is in such terrible array. I mean, we've just heard that actually funding for mental health has been cut over the last 3 years in a climate where there were such promises that mental health was going to, get more money, more services, more staff, and so on. The reality is it's still the Cinderella part of the NHS, the Cinderella Service, and its funding is being cut. So, I mean, we haven't talked about young people very much. The massive amount of there's massive issue around young people and mental health. I mean, Finn and Leah mentioned it. I didn't say anything about it, but it would be very good in mental health action for us to have people who are involved in one way or another, however, around young people's mental health. Lots of other areas similarly that we can hardly touch. And the idea of a national campaign around everything is just incredibly difficult. And we're doing some work on preventable future deaths. And 2 or 3 areas are represented. Again, it's Leah and Finn have done so much work around this in Norfolk. But to try and get a national picture and a national campaign, really difficult. So that's what we're hoping for gradually with mental health action. So my message is really join us, get in touch with us and join us if you've got any time and any energy to do some campaigning work about mental health. Please join us. Let us know that you'd like to be in touch with what we're doing, and we can send out, we can send you reports on sort of what's happening and ways that you can sort of join in.
Paul,
Yeah.
Paul, and also just maybe can I make also a suggestion just at the back of what you just said?
Yeah.
I think it's really, you're absolutely right, because it can feel so overwhelming as well to know how to tackle this huge issue. And for me, I really remain with that sentiment that almost scrutinizing the NHS can also be a grieving process for a lot of us, because we feel that, you know, is so dear to us. We also want to do it with care and respect and the love that we have for the NHS. Now, as many of you might know, the NHS, the 10-year plan, the 10-year NHS plan, is being rolled out in terms of the initial plan, for community mental health are being talked about in different local authorities and ICBs. It might be worth that our next session that we have is around us coming together to propose what that community mental health proposal should be. Like this, in a session like we just done here today, and then we can take that and send it to ICBs. I'm a counselor in Hackney, and a proposal came to the council, and I saw very sadly that talking therapies continue to have a prominent role in this 10-year plan in terms of mental health community. It's not yet set on stone, so it feels that there is a moment in which we can come together and set our agenda, saying that this is what we think should be, this is what community therapy should look like. Just a small suggestion. I don't know what people think, but it could be that could be an action. What do people maybe think? Does that? I see a few noddings, yeah? I see a few thumbs up. What do you think? I think, yeah, I mean, coming together for that.
Yeah.
Yeah.
I'm being very counselor, like, let's take action. Let's scrutinize next. Sorry. I might not be elected in 5 more weeks, so it's my last chance.
I think one of the things that's been really important to me is putting community mental health, as Leah and Fen have been talking about it, which is clearly so important on the mental health politics scene, but putting severe and more ongoing mental health issues alongside common mental health to join forces, because the issues actually are very, very similar, even though the severity or the intensity of the experience of lack of real compassion or care, is so often on a different scale. So, yeah, I think that would be good. And perhaps people have suggestions for what we might campaign about or meet to talk about in a deeper way. That they could send to us and let us know. And
we have okay, so just as we wrap up then, before we conclude, so we have the details of all of you. If that's okay, we can send information about as well the mental health action group is here in the chat as well. I can see some people of you nodding, which is great. You can join us, and then hopefully we'll see you very soon, either our next meeting and then start organizing from there. Thanks, everyone. We're going to have this session live on YouTube very soon. Really massive thanks to Leah, to Fen, to all of you. This has been really inspirational. And for me, as a mental health therapist and myself, someone who struggled with my own mental health, and my community helped me, I find it quite healing as well. So thank you so much. Thanks, Paul. Thanks, Terry. Thanks, Frank, everyone, the team. Thank you so much, everyone. As we say in Bolivia, hayaya. And thank you so much.
Leah and
See you
Fen,
next
for a
time.
fantastic presentation. Thank you so much.